Good morning, everyone. Today we are continuing our urology Viva preparation. The topic is testicular cancers. We already done the testicular cancer topic a few times in the past, but it's always nice to revise, and also every time we revise, we will come across new questions, and also we can explore some new areas which were not covered in the previous sessions. Thank you for the trainee who has agreed to record this session, which will be a good revision resource for the future. We'll start. You have a 32-year-old gentleman presented to your clinic with right-sided testicular swelling noted for past 1 week. How are you going to proceed?
So I will assess him in my dedicated 2-week weight cancer clinic with the urology cancer nurse specialists. I'll take a focus history to confirm the side of the swelling, the duration, if it's been getting any bigger, whether there's any associated pain or overlying skin changes. I'll ask about any associated lower urinary tract symptoms. I'll take a sexual history, and I'll confirm about any contralateral swellings and systemic symptoms, including tiredness, fatigue, and shortness of breath. I'll establish a past medical and surgical history, including that of any previous undescended testes and orchidopexy, as well as testicular cancer. I'll ask about a family history of testicular cancer, and I will determine whether the patient has a family and has completed this. I'll then perform a chaperoned physical examination. I'll perform a general examination to include the respiratory system and examination for supraclavicular and retroperitoneal lymphadenopathy. And I'll then examine the external genitalia to note the presence of a mass, the size, whether it's arising from the body of the testes, any tenderness, and whether it's transilluminable.
Okay, I will just add surgery in the genital or inguinal region to the history because there is a possibility patient may had previous hydrocele surgery or scrotal exploration, and that incisions will make impact, or history of trauma in the lower abdomen or genital region that will make an impact. Examination, I will include is there any presence of gynecomastia because of the hormone secretions from various types of testicular cancers.
Yeah.
You can include the supraclavicular lymph nodes, which is very specific for testicular cancer. And you can say I will examine the patient in the standing position, and also in the lying you can complete the examination. Digital rectal examination is not very specific for testicular cancer, but it will be useful if the patient is more than 40-year-old.
Yeah.
This patient gives an history of undescended testes, and he had surgery in the age of 5. How important is this?
This is important because undescended testes is associated with an increased risk of testicular cancer. 5% of patients who, between 5 to 10% of patients with testicular cancer have had a previous history of undescended testes, and the relative risk of developing testicular cancer with a history of undescended testes is overall between 3 to 10.
Okay, the relative risk is 4 to 6, and the risk will decrease if the orchidopexy is done before pubertal age of 13.
Yeah.
What is the risk of tumors in a patient with past history of intratumor germ cell neoplasia?
So if there is ITGCN present, then the risk of an invasive testicular cancer occurring within the next 5 years is 50%.
Perfect. What is the chances a cancer can be bilateral?
This is 5%.
Okay, 1 to 2%, I will say. What is the normal peak of incidence in age for testicular cancers?
This can depend upon the type of histological type. So if it's a non-seminatus germ cell tumor, then the peak is in the fourth decade. The third decade, and if it's a seminoma, then it's in the fourth decade, i.e. between the ages of 13 and 40.
Perfect. So this patient you are examining, you are able to feel a nodule on the right side, quite suspicious. Otherwise, left testis is normal, examination is normal, no supraclavicular lymph nodes, no evidence of gynecomastia. Quite fit, normal built gentleman, sexually active with his partner, no children in the past. No specific reasons, just started the planning for the family quite late. How are you going to proceed further?
In the presence of my urology cancer nurse specialist, I will explain my findings to the patient and that they are suspicious of an underlying new testicular malignancy. I will explain to him that he needs further urgent investigations and management. I will arrange for measurements of baseline blood tests in the form of full blood count, renal function, but also tumor markers through the alpha fetoprotein, beta HCG, and LDH. I will request a staging CT scan of the thorax, abdomen, and pelvis, but most importantly, I will go to the radiology department myself with a patient and request an on-day ultrasound scan of the testes.
Is there any role for cerebral imaging?
The EAU guidelines on testicular cancer advise CT head be performed where there is a non-seminatus germ cell tumor, pulmonary metastases, and where the patient is in a poor prognostic group. And this is determined where there is the presence of a beta HCG of more than 5,000 or an AFP of greater than 10,000 or non-pulmonary visceral metastases. And also if there's a choriocarcinoma.
Okay. Any role for MRI in testicular cancers?
MRI scan of the testes does, compared to testicular ultrasound, does have a higher sensitivity. However, it is more expensive to perform. It's logistically more difficult to arrange. It won't be arranged in a time frame, and therefore testicular ultrasound remains the mainstay of imaging for testicular cancer.
Any role for bone scans?
Bone scan has a limited role. Bone metastases are uncommon in testicular cancers, so they're not routinely recommended.
You can say bone scan has no role because the chances of bone metastasis is impossible and not documented. Even in the staging, there is no M staging for bone mets.
Yeah.
Okay. What is the importance of serum tumor markers?
Tumor markers in general allow to determine, so they can act as a marker for or a screen for potential malignancy. They can be used to monitor the response following surgery, the response to further treatments. In the case of LDH in testicular cancer, it is used to determine the tumor burden. And in terms of the specific tumor markers for testicular cancer, they can point towards the histological type of cancer that is likely to be present.
Okay. After doing serum tumor markers, will you repeat in relation to your orchiectomy?
I will repeat them at 5 to 7 days post-orchidectomy.
Which one is important?
The most important tumor marker, I think, will be the beta HCG, and in terms of testicular cancer, it'll be the beta HCG and alpha fetoprotein.
Okay. Which tumor marker testing is important, pre-orchiectomy or post-orchiectomy?
think pre-orchidectomy, because that's at the time of initial diagnosis.
Yeah. Pre-orchidectomy is important in making a diagnosis and it will complement our ultrasound and examination findings. But pre-orchidectomy tumor markers could be elevated due to the tumor in the testis itself. So post-orchidectomy, if the tumor markers become negative, that gives a kind of like a cancer clearance, and hence post-orchidectomy presence of positive tumor markers is very important for further staging and treatment decisions.
Okay.
What type of tumors will secrete these tumor markers?
Beta-HCG is secreted. So both AFP and beta-HCG are secreted by the non-seminomatous germ cell tumors. So beta-HCG is elevated in 40 to 60% of these, and AFP in 50 to 70%. 100% of choriocarcinomas secrete beta-HCG. With seminomas, only 10% will secrete beta-HCG, and none of them will secrete alpha-beta protein.
What is the importance of LDH?
So LDH is not specific to a histological type of testicular cancer, but is more a marker of tumor burden.
Good. What is the half-life of tumor markers?
Half-life of AFP is 5 to 7 days, and beta-HCG is 36 hours.
Okay, so how are you going to proceed with this gentleman?
So I'll explain the findings to him again with the urology cancer nurse specialist present. Sorry, can I just confirm, has he had an ultrasound scan done?
Yeah, he had ultrasound scan which proved your examination findings of testicular tumor measuring 2.3 centimeter in the right testis.
Okay, so I'll explain the scan findings to him, that again they have confirmed my suspicion of this being a malignancy, and that likely being a malignancy, and that it should be treated as a cancer until proven otherwise. I will explain that he needs to undergo a right radical inguinal orchidectomy on the next kind of on an urgent, semi-urgent elective basis on the next operative list. I will counsel him about the procedure using a BOUS procedure-specific patient information leaflet, and I'll outline the benefits, risks, alternatives, and the way the procedure is performed. I'll explain that the benefit will be treatment of potential testicular cancer and obtaining diagnosis. I'll explain the alternatives would be no further surveillance, but it would not be recommended. And I'll outline the risks of the procedure, with specific risks including bruising, scrotohematoma, and abscess formation, ilioinguinal nerve injury causing chronic pain, the fact that this could be negative histology, and the need for additional treatment. I will also counsel him about the insertion of a testicular prosthesis at the same time for cosmetic reasons, and the associated risks with this, including contracture, migration, unsatisfactory cosmetic appearance, erosion, and infection. And I will also offer this patient preoperative sperm banking, given that he has been planning to have a family in the future.
Is there any disadvantages of having testicular processes on the same time, and any evidence to that?
You say advantages, sorry.
Disadvantages?
Disadvantages. Inserting a testicular prosthesis at the same time with the presence of a foreign body is thought to increase the risk of sepsis if the patient undergoes chemotherapy. However, there have been studies to perform which demonstrate that there was no increased risk in sepsis in this setting, and that the prosthesis, there was not an increased risk of removal of such prosthesis, although I can't quote the exact studies involved.
Yeah, it's Robinson et al. BJUI 2014. What precautions you will take to prevent infection if you are placing testicular processes on the same time?
So in order to prevent infection, I will preoperatively screen for MRSA and ensure this is treated if present. Intraoperatively, I will ask for antibiotic prophylaxis as per the PU checklist. I will adhere to the principal surgical techniques in terms of non-touch technique, shaving the skin, or with clippers and not a razor, dipping the prosthesis in betadine, and also handling it not with my gloves but with a clipper, and ensuring that the patient has appropriate postoperative instructions in case infection does develop.
What prophylactic antibiotics you prescribe?
So I'll prescribe intravenous Comoxiclav, provided the patient is not penicillin allergic.
Okay, you can say that you will give 24 hours antibiotic cover. Nothing wrong with one dose, but in general, coamoxiclav, if not third generation cephalosporin, 24 hours coverage is good for any prosthesis like inguinal hernia, mesh repair, etc. How are you going to fix the prosthesis?
So on one pole of the prosthesis is a little hook. So I'll fix this by placing a 3-opedia suture through this, everting the scrotal skin after the testis has been removed, and anchoring the prosthesis to the inferior aspect of the scrotal sac.
Any specific advice you will tell the patient post-op?
So I'll advise them that no, I don't know.
Yeah, it's like you need to explain the patient that the prosthesis is placed, and he needs to handle the testicular prosthesis so that the scrotal skin will not go for a contraction. Any foreign body implanted, the body will try to expel it. So there is a possibility of upward migration of the prosthesis towards the incision and also the skin contraction. So maybe after 24 to 48 hours, once the soreness of incision settle down, it is advisable for the patient to kind of massage the testicular processes so that the scrotal skin get nicely released, and also there is no upward pull or the scrotal contraction as you explained before.
Okay.
Our gentleman has no child, so what special things you will do before orchiectomy?
I'll offer this patient sperm banking, and if he does accept this offer, then he needs to provide at least 3 sperm samples with a minimum of 3 days abstinence beforehand, and this should be produced via ejaculation. And if he's having sperm banking, then he also needs to have viral serology to screen for HIV and hepatitis B and C.
Okay, so how the sperm is stored?
It's stored in liquid nitrogen at a temperature of minus 40 degrees Celsius.
It's minus 196 degrees Celsius. And how long the sperm cryopreservation can be done? How many years?
For up to 25 years.
Okay, sperm cryopreservation can be done indefinitely, and they can have it for generations. But for NHS, we can preserve it for 12 months, 1 year, and more than a year, the patient has to pay from his own pocket. Normally, the sperms are preserved for 10 years or until the patient reaches the age of 55, whichever is earlier. There may be some small changes even now and then, but usually they won't ask more than this.
Okay.
What is the role for contralateral biopsy when you're doing right side orchiectomy?
Contralateral biopsy would be performed to look for evidence of IT-GCN, and this should be considered in the presence of risk factors. And these are if the patient is under the age of 40, the contralateral testis is less than 12 mils, if the patient is subfertile, or if there is a history of previous undescended testes.
Okay. Our patient had history of undescended testes surgery, so it will be very nice if you have brought this to the discussion. But the opposite testis is normal in size, so there is no indication for contralateral biopsy, and also there is no need for biopsy in patients older than 40-year-old without any risk factors.
Yeah.
Okay. How will you histologically classify the testicular cancer?
So histologically, it can be split into non-seminomatous germ cell tumours, which comprise of teratomas, teratocarcinomas, embryonal cell carcinomas, yolk sac tumours, and mixed tumours in choriocarcinoma. There are seminomas, and then there are sex cord tumours, which account for 5% of testicular tumours. And these include Leydig and Sertoli cell carcinomas, granulosa cell tumours, and gonadoblastomas.
Okay. The other simple method is 2016 WHO pathological classification into 5 groups: germ cell tumors derived from germ cell neoplasia in situ, germ cell tumors unrelated to GCNIS, fourth sex cord stromal tumors, fifth one miscellaneous non-specific stromal tumors. How the staging works in testicular tumors?
So the staging that I'm aware of is the TNM staging. TIS refers to presence of IT-GCN. T1 is when the tumour involves the is limited to the testes and tunica but there's no lymphovascular invasion. T2 is when it involves the tunica albuginea and tunica vaginalis, or if there is lymphovascular invasion present. T3 is when it invades the somatic cord, and T4 is invasion of the scrotum. In terms of the end staging, N0 is no lymph node involvement. N1 is involvement of a single lymph node up to and including 2 centimeters. We're talking about regional lymph nodes. N2 is involvement of at least one regional lymph node of more than 2 centimeters and up to 5 centimeters, up to and including 5 centimeters. And N3 is involvement of at least one single regional lymph node more than 5 centimeters. And then in terms of the M staging, M1A is non-regional lymph node involvement or lung metastases, and M1B is non-pulmonary visceral metastases.
Yeah, M1B is non-regional or non-lung distant metastasis. Whatever other than M1A, everything will come to M1B.
Yeah.
In N1, it is single or multiple lymph nodes, but the greatest dimension should be less than 2 centimeters.
Okay.
How will you use serum tumor markers for staging?
There is a additional staging called the S staging, depending on the serum levels of the tumor markers. So S0 is when they are within the normal range. S1 is when at least one of them is elevated, but up to 10 times the lower limit of normal. S2 is when they are elevated, when at least one of them is elevated to between 10 times the lower and upper limit of normal, and S3 is when at least one is elevated more than 10 times the upper limit of normal.
Yeah, you can divide. You can divide this into 3 tumor markers: LDH, HCG, and AFP. For LDH, S1, S2, S3 is less than 1.5 times normal, 1.5 to 10 times normal, more than 10 times normal, S1, S2, S3. For HCG, remember 5,000 and 50,000. So less than 5,000, 5,000 to 50,000, more than 50,000. For AFB, remember 1,000 and 10,000. So S1, S2, S3 is less than 1,000, 1,000 to 10,000, more than 10,000. So you can remember HCG 5,000 and 50,000, AFB 1,000 and 10,000. That will help you.
Yeah.
In the tumor, when you are explaining TNM, don't miss the X staging, NX, TX, MX, SX, which is very easy to add, where the particular regional lymph node can be assessed, serum tumor markers not available, so you can put it as X also.
Yep.
How will you predict the relapse once you get the histology of the tumor?
So this depends on the histological type of tumour, and they have their own risk factors for relapse. For seminoma, the risk factors include the tumour size of more than 4 centimetres, or Reti-testis invasion, and for non-seminomatous germ cell tumours, this is if there is lymphovascular invasion present.
Any percentage, if the risk factors are present, what is the percentage of relapse?
So for seminoma, if there is one risk factor, then this is 16% at 5 years. And if it's got 2 risk factors, then it's 32%. Whereas for non-seminomatous germ cell tumour, if vascular invasion, lymphovascular invasion is present, then this risk is 48%.
Yeah, if it is present, almost 50%. If it is absent, it is 15%. Okay, if the patient's histology shows germ cell neoplasia in situ, how are you going to proceed?
So I'll see the patient. So I'll discuss this patient first of all at the MDT, and if there's a SMDT as well with a specialist testicular cancer centre, then I'll discuss it with them. This patient's chance of invasive carcinoma is 50% at 5 years, and they now have a solitary testis, but we said that was normal. So the options would be either, I think, given he's got a solitary testis, it would be radiotherapy with 18 to 20 grays in 2 fractions.
Okay, 20 grays in fractions of 2. So 10 fractions in fractions of 2. If the opposite testis is normal, there is an indication for orchiectomy or close observation.
Yeah.
Okay, your patient histology shows seminoma, pure seminoma, 3 centimeter in size, no Reti-testis invasion. What are all the options?
So the options for this include surveillance, or they include a single dose of carboplatin chemotherapy.
Okay, how will you decide carboplatin? What may be the dose?
Don't know.
Okay, for carboplatin, the dose is explained as AUC7, area under the care 7. It is a kind of online calculator where if you want the chemotherapy AUC to be under the 7, you need to input age, sex, creatinine, tumor markers, and it will automatically give you how much milligrams of carboplatin has to be given. So the treatment options are 1 cycle of carboplatin AUC 7, or we can wait for surveillance.
Yeah.
So how will you decide about radiotherapy versus chemotherapy for stage 1 seminoma?
Radiotherapy would be offered if there is evidence of regional lymph node metastasis, and chemotherapy would be offered if there is no such evidence, and also if the patient desires to undergo chemotherapy instead of surveillance. And it would also depend upon the other factors, including the patient's renal function and general fitness for chemotherapy.
Yeah, you can bring in MRC and EORTC trial, and also we have the Spanish Sventosia trial. So it all depends upon the risk factors. If there is no risk factors, surveillance will give good follow-up with 4% of recurrence or relapse, while carboplatin one course will give 2% of relapse. If there are one or two risk factors, as we discussed, surveillance will give 15% of relapse and carboplatin one course will give 9% of relapse. Two courses of carboplatin is explained, which gives only 1.4% relapse, but the follow-up is only 34 months. What will you do for non-seminomatous germ cell tumor stage 1?
So for this subgroup of cancers, the management would be to offer 6 cycles of BEP chemotherapy, which consists of bleomycin, etoposide, and cisplatin.
Okay. Any modifications you need to do based upon the side effects?
So each agent has its own specific side effects. So bleomycin can cause pulmonary fibrosis. Etoposide, I think, not sure what the side effects are, but cisplatin can cause nephro, neuro, or ototoxicity. So the doses can be reduced, but I don't know if there are any alternative agents that can be given.
Yeah, if there is a significant decrease in the pulmonary function, you can skip the bleomycin and you can give only etoposide and cisplatin. You can bring in MRC trial 1996 or Sventosia trial 2014. How will you plan RPLND for stage 1 non-seminomatous germ cell tumor?
So RPLND in this scenario would be indicated following chemotherapy if there's a residual mass of greater than a centimeter and where tumor markers are normal. So this would be planned for with a restaging CT scan of the thorax, abdomen, and pelvis. And I would plan for this by also determining the side of where the original tumor was, and counselling the patient for the procedure using a procedure-specific patient information leaflet.
Okay. Because of the excellent chemotherapy, RPLND is fallen out of favor, and it's more suitable for patients with teratoma with somatic malignant component if the biopsy of the testis shows. So that is where the primary RPLND has more role. In case if the patient is not suitable for chemotherapy, then RPLND has a role. Now, if the patient has stage 2 A or B seminoma, what is your treatment approach?
So for stage 2, the option remains with 6 cycles of BEP chemotherapy, but also radiotherapy.
Okay, and non-seminomatous, any role for RPLND?
There is a role for RPLND in non-seminomatous, again, where there's a residual mass following chemotherapy, more than a centimeter, but only where the tumor markers are normal.
Yeah, if there is no tumor markers, if it is S0, in non-seminomatous patients, RPLND is preferred, or 2 cycles of BEP. If it is S1 tumor marker staging, then 3 cycles of BEP. What will you do for metastatic germ cell tumors? How will you approach?
So if a diagnosis, so following the initial assessment and pre-surgery, if the staging CT does demonstrate evidence of metastases, then if there are lung metastases, then I'll discuss this urgently with an oncologist, because it could be that the patient requires upfront chemotherapy urgently before they have their surgery, especially if they are symptomatic.
Okay, so we need to make sure that the patients are treated with upfront chemotherapy because it is quite a rapidly progressive disease and there is no need to really wait for orchiectomy. And orchiectomy patient requires anesthesia in case if there is a significant pulmonary metastasis that will also result in a bad outcome. How will you classify the patients with metastatic testicular tumor post orchiectomy?
So they are stratified according to risk groups of good, intermediate, and poor prognosis. And this depends upon the tumor markers and also the distribution of their metastases. So good prognosis would be those with normal tumor markers, no evidence of metastases, and in terms of the TNMs, the T stage can be T1. Intermediates would be S1 to 2, PT2, and M1A. And poor prognosis would be PT4, S3, and M1B.
Okay, how I will approach this is International Germ Cell Cancer Collaborative Classification divides, as you said, into good, intermediate, and poor. Non-seminoma into three groups, while for seminoma it's only good and intermediate, there is no poor group. So establish this one. And then for the good group, it is testes for the non-seminoma, testes or retroperitoneal primary. So it's not T1, it's more than T1. So testes or retroperitoneal primary, no non-pulmonary visceral metastasis, and tumor markers S1. You can bring in S1, which automatically ticks the box like AFP less than 1000, HCG less than 5000, LDH less than 1.5 times upper normal limit. For seminoma, again, AFP will be normal, any HCG and LDH, because usually tumor markers are not very significant for seminoma. Any primary site, no non-pulmonary visceral metastasis. This is good prognosis group. For intermediate prognosis group, in non-seminoma, you can bring in S2 staging. This is where the S1, S2, S3 staging will be very handy for you. You don't have to explain everything again. You can just bring S2. And seminoma, it will be again any primary site and non-pulmonary visceral metastasis will make it intermediate group. Poor prognosis group, non-seminoma will be of mediastinal primary and the tumor markers will be S3. That is poor. Okay?
Yeah.
Good. So if there is a clinical stage 1, what about the contralateral testes? How will you approach?
So with the contralateral testis, this will be managed via active surveillance, so advising the patient to self-examine themselves regularly and to contact the urology nurse specialist if there is any changes that they notice in it, so that an urgent repeat ultrasound can be performed. And also measurement of regular measurement of tumor markers at specified intervals.
How will you manage residual tumors after treatment? Seminoma.
Is this so retroperitoneal?
Yeah.
If this is, for example, seminoma following chemotherapy, and there is a residual mass of greater than 3 centimeters, then I will request a PET CT scan, but this can only be performed at least 8 weeks following chemotherapy. And if this is demonstrating avidity, then the patient would be candidate for further chemotherapy. And in the case of non-seminal germ cell tumors, if there are, again, such residual masses, this wouldn't be an indication of a PET, but they could be offered retroperitoneal lymph node dissection, or they could undergo further cycles of chemotherapy.
Okay, so FTG PET is indicated only in case of seminoma. In non-seminoma, there is no role for FTG PET. What are the possibilities in non-seminomatous residual mass after the first line treatment?
In terms of residual masses, most 50% will demonstrate no viable tumor. The 10% have mature teratoma, but the 40% demonstrate evidence of ongoing tumor within the mass.
Okay, that ongoing tumor, I mean, like 6 to 10% residual mass contain active cancer, and in the remaining 90%, 50% will have post-pubertal teratoma. You need to bring in teratoma, and 40% is the necrotic tissue, as you said. If the size is more than 1 centimeter, patient requires bilateral RPLND. If it's less than 1 centimeter, we can observe, but chances of recurrence is 9%. Good. That's a very nice comprehensive discussion on the testicular tumors. I will say the first 80% of the discussion is very important. Presentation, examination, investigations, tumor markers, staging, orchiectomy, testicular processes, and stage 1, because this is what usually the urologists do. You are very strong in that. I have no concerns with anything, except for the fact that at some points we started discussing quite generally. We need to bring back into that particular patient, 32-year-old, no children, sexually active, so cryopreservation and how to help with his family completion. So those things should be brought by yourself. Once it is done in a very strong manner, usually you will have like a minute or minute and a half where the examiners will try to take you into the areas of stage 2 and IGCCC risk stratification and the role for RPLND and FTG PET. Once you are in that area, you are already in a very, very good stage. Testicular tumor markers are usually very straightforward. There is nothing much to deviate. The questions will be exactly in the same order like how we discussed today. The only thing is, the one scenario will not have both seminoma and non-seminoma. Usually they will take seminoma and take you in that angle, but because of the training, I just want to cover both seminoma and non-seminoma parallelly. Particularly stage 2 chemotherapy, I haven't touched much because the chances of hitting there will be very rare. But if you are getting a little bit confidence in those areas, what is AUC, how AUC is calculated, why it is AUC 7, those are all giving you the extra brownie points. Okay?
Yeah.
Good. Any questions from your side?
So I think probably the only other thing in my mind is in terms of management of GC NIS, where you've got a solitary testis left. Because I mean, the patient, one presumes would have then undergone sperm banking and so on. So to the solitary testis, you can still give the radiotherapy in fractions of 2. Or observation still be another option.
Yeah. For GCNIS solitary testes, local radiotherapy, 20 gray in fractions of 2 gray. So there will be 10 fractions. If the opposite testis is normal, we can do orchiectomy of the diseased testes. That will resolve everything. No need for long-term follow-up, or patient needs close observation. Chances of developing overt testicular cancer is 50%.
Yeah.
Good.
Okay. Yep.
Very good. That's a quite comprehensive discussion again. Any other questions before we complete?
No, there's none that come to my mind. I'm sure I'll contact you personally if anything does come to mind.
Yeah, just send a message. If it is small issues, we can cover it. Obviously, we will do some more testicular cancer scenarios before your exam.
Yeah.
Well done. Have a nice rest of the day. I hope once you start your study leaves, we can do much more frequent sessions, and also we do timed 10-minute sessions.
Yes.
Good. Have a good day.
Thank you. You too.